Hi, good evening, everybody. Welcome back to another webinar by Beating Heart. I'm Dr. Betty Tay, the host for tonight, as usual. I want to wish you first and foremost, Happy Chinese New Year to all. Okay, hopefully we will have a better year than last year and have a very good year ahead of us. There is a lot of hope now, especially with the vaccine showing a lot of in the numbers of patients dropping worldwide. Today I have here with me Dr. TECK, who is not my psychiatrist, not yet anyway, but a very good friend, a very dear friend. He and we were in the same university, the same year. And Dr. Yan has his own practice in my brain and mind specialist clinic. And as we all know, anxiety and depression and mental health problem is a true and real issue these days among all of us, all walk of life, all ages. And I think we can do with a lot of help. And let's start with the talk, Dr. Yan. And this is the first time we have a talk that is actually like an interview based, and it is also the first time we are actually putting it all live Facebook for the public. So Dr. Yan, welcome to on board to the show. I think this is your first time with us, Beating Heart.
Yes,
How
thank
have you been?
Yeah,
It's your
fine.
Chinese New Year?
So every Chinese New Year, eat and sleep. You don't go anywhere.
Okay.
So I
So
wish,
maybe
I thank you, Beto Betty, for inviting me. And
let me just ask you a few questions.
yeah,
Okay. Over the years, how prevalent has this anxiety and depression been? Is it growing a lot?
yeah.
Sorry, there's a lot of background sound.
Okay. You see, and now I'm talking about depression, anxiety in terms of medical problem, right? So I'm not
Yes.
talking about, because every day there are a lot of people who feel sad, happy, angry, frustration. That's are not illness. So today I'm talking about the medical part of depression and anxiety, right?
Okay.
So when you read back all the ancient scripture, you see all the denote the depression and anxiety for million to thousands of years already present. Just at the time, we do not know this is a medical problem. So now we find a lot more, I think it's because people willing to talk about it, people willing to come forward and share their pain and their recovery. And there are people who start support group. That's why we think it's a lot. I think that it's the same.
Oh, you think it's the same?
I
So
think
what
it's
you're
the
trying
same.
to say is that anxiety and depression as a disease, just like coronary artery disease or
Yeah.
cancer, okay, the prevalence is about the same now, 10 years, 20, 30 years ago.
Yes,
Okay. Okay.
I would think that way.
You think that way. But
Yeah,
do
maybe,
you,
yes.
okay. Now, as a disease, okay, now let's take a cut-off point where this is disease, anxiety and depression is a disease, whereas everyone else is angry or having some kind of palpitation due to work stress or even emotional stress due to family problems, those you do not consider as a disease.
Yeah, no.
But do they need treatment?
When you read the textbook of classification of mental illness,
Okay.
from page 1 to the last, you'll find that some of the symptoms you are having it, but it doesn't mean that you need treatment, right? Because the crucial point in treatment is the disruption of function. Disruption of function means cannot go to work, cannot go to school, cannot interact with your family or your friends. So your function is already disrupted. So that will put it, you need treatment, right?
Okay. But in terms of stress, for example, the life that we lead now compared to the life that our parents lived, is it not an aggravating or precipitating factor to more anxiety and depression?
Yeah, later I will talk in detail. But you see, in medical, I will divide into two groups of illness.
Okay.
Some
You have some
illness is
slides
very
ready, right?
simple.
You want to do
Yeah.
your slides first, or you want me to? Okay,
Yeah,
I think
okay.
maybe you do your slides
Okay.
first, yeah?
So another thing is, I think there's a lot of lay people. So some of the slide is a bit, what I call it, technical, is for the medical student and medical doctor. So some slide will skip quite fast.
No,
right?
it's okay. You can go on.
Right?
Yes.
So I explain to how we look at disease.
Okay, the main importance here is, of course, still the doctors and the medical graduate. So we will talk in depth as your slides show. Okay, but we will take questions from both audience later.
Okay.
Okay.
Now, okay, let me start this talk by make other people very clear in their mind. So let's say, for example, I exposed to pulmonary TB bacteria. I infected with TB, simple. COVID-19, I got COVID-19. But there are a lot of illnesses, just like diabetes, high blood pressure, ischemic heart disease, psychiatric disease. We call it multifactorial. So that means there's a genetic, there's environment, nature, and nurture interplay. So my talk, we're going to this area, okay? So that's why I put the neurobiology of depression, but actually you seldom see people who have 100% depression or 100% anxiety. They both come together, and which one is more, right? Let's see, second slide. So how do we know, am I or Dr. Patty and the audience, are we normal people or we are sane people, right? So now, so there's a lot over the years, 100 years, 1,000 years, there are a lot of people quote about the chain of mental state, right? So there are a few of them, right? So I go to another one. Now, for example, so Lita Mae Brown, and she said the state of insanity are that 1 out of every 4 Americans is suffering from mental illness. Think of your 3 best friends. If they are okay, then it's you. So it's very common. So you see now, it's those who sitting with 4 person. You ask from your right, are you okay? If the 3 person say okay, then it's you who are not okay. Now,
well, you are one of my best friends, and you are definitely not sane.
So just like these 2 person, is it the mad fella or the sane fella? We do not know. Maybe for another 4 years later. Now we talk a bit about the data that we know. Okay, this one is the survey in Europe, right? Over the course of 12 months, 27.4% of adult in European Union population, equating to 82.7 million suffer from mental illnesses. 27%, right?
Oh.
So mental disorder is 12% globally, estimate increase by 50% by 2020.
面包有 butter 吗？你不可以吃。
现在才吃饭吗？吃 butter 不大好啊，吃 okay. Now, so I can speak Mandarin also. All right, so we go to the next slide. Now, this is very interesting slide. On the dark blue, estimate 1990. Okay, you look at it. Number 4 is unipolar major depression. Okay, we're talking about this DALY because you wouldn't die from depression. But what they do is they cause a lot of disability. So in the year 2020, that was last year, so unipolar depression will be ranked number 2. But of course, the first one still ischemic heart disease, right? So you see how severe then? How about Malaysia? Do we have data? Yes, we have a bit of data about Malaysia. So this one is the major burden of disease injury study 2004. They find that mental disorder contributed 7.3% of burden of disease in Malaysia, ranked second to cardiovascular disease. Well, then there's a lot of self-inflicted harm, suicide rate. They're going to increase. Now, National Morbidity and Health Survey for 1996 and 2002, prevalence of psychiatric morbidity was 10.7 and 11.24. So I'm sure 2020 is much higher. Right? So now, so this is a mental health registry. Now with the mental health registry by MOH.
Sorry, hold on. You guys mind muting yourself, please? On, sorry, and
Wow. So this is about on schizophrenia cases, right? We do not have depression. What we have is schizophrenia, right? In year 2023, we had 2,287 new cases. Then 2005, 2,500. This is MOH only, but I'm sure it's more than that. It's the tip of the iceberg, right? It's a tip of the iceberg because a lot of people, they go to private and it's not captured, right? Just imagine, we talk about psychosis. Psychosis is quite a terrible illness in psychiatry. The duration of untreated psychosis is 28.7 months. So the
okay, at this point of time, can I just stop you here?
Yeah.
Because we have a group of public. So can we just tell them what the psychosis mean?
So psychosis means that you have experience that normal people would not have. For example, you can hear voices other people can't hear, you can hear, and you find that a lot of things have significant meaning for you. For example, you think your neighbor talking bad about you, but your family member say, no, no such thing. Our neighbor is
Also
fine.
like paranoia?
This suspicious and paranoia, right? So, and the people say TV giving signal, and they feel that the husband going to kill, harm her, right? So this is under
Like
psychosis.
hallucination and delusion?
Yeah. So we break into two. Hallucination meaning that you see, you hear, you smell, you feel the things that are not there, but you can feel it, you can see, you can hear. Then delusion means that it's a false belief, right? No matter how the family member explain to the person, even give any proof, explanation, but the person still firmly held, no, it's not true, right? The neighbor is doing some harm to us. So that's why I see patients who moving house 3 or 4 times per year. Why? Because every time in the new house, she or he claimed the neighbor try to disturb them. So they move house. Okay, so this is psychosis. Today we are not talking about psychosis. It's just some
we're
data
not talking
only.
about psychosis.
Yeah.
Just...
Now we talk about depression. So I'm not talking about those. Yeah, you scolded by your boss. You didn't reach KPI. You didn't have increment. You are sacked. Your salary will reduce. I'm not talking about this kind of depression, right? Now
you're not talking about situational kind of depression,
right?
Okay.
So
you're talking about disease that is in itself.
So when you see the disease, it is different. You can see them, those who suffer before or those who have family members who suffer is different. The sadness is prolonged, okay? It's prolonged, the sadness. So we have the emotional symptom on my right, on the right side of the top box. Then your tearfulness, for no reason, easily tearfulness, right? Then you have guilt. There's ridiculous, the guilt is too much. Actually, nothing to do with him or her, they find it is their fault, right? Of course, when you talk about suicidal thought, I think the one straight away go for treatment, they don't wait anymore, right? So lack of interest, anxiety, irritable. Then how about physical symptom? That means lack of energy. The patient will tell you, no, I want to sweep the floor, but I just do not have the energy. I just want to lie down and sleep, but I can't sleep. So change your appetite, change sleep. So psychomotor slowing, that means you just cannot move, you just want to sit down or sleep only. Then restlessness, agitation, pacing up and down, right? Then cognitive means what? Cognitive, for the lay people, we refer to how our brain see things, interpret, and make decision. Right? For some cognition to deal with decrease of concentration. Very classical. Are you able to read the newspaper or watch TV? Oh no, doctor, I don't know what I'm doing. I just look at the newspaper or I'm blank. I watch TV, there's nothing coming into my mind, right? Poor memory, absent-mindedness, right? Then obsession, repeating the same thing again, detachment, right? They just cannot feel happy, like to call it anhedonia. You like to play mahjong, now I say, no, I don't play mahjong. You love the grandchildren, oh no, please don't come. It's very noisy, the grandchildren, right? Then of course, the associated symptom, pain, then you have palpitation, all kind of thing. You see, the problem between depression and medical illness. Severe depression will make the BP, the blood pressure, and sugar level uncontrolled. Uncontrolled sugar level and blood pressure also cause depression. So it's interrelated. Okay.
See,
Yeah. So that's why if your depression not properly treated, your other medical illness become worse.
okay. And the reason why they have this uncontrolled high blood pressure or diabetes, is it because of the fact that they don't take the medication, or is it because
No.
they don't adhere to, let's say, normal lifestyle like exercise?
You see,
Or
when
is
you
it inherent with the
inherit,
disease
when you are,
itself?
when you depressed, what's going to happen is the HPA, the hypothalamus pituitary system become haywire, and
I
a lot
see.
of hypercortisone starts circulate. So if a lot of cortisone secretion, what's going to happen? Your sugar will be not able
It's like,
to maintain,
I
and
see, it's like
the
taking
BP.
steroid.
Yes. So the hyperactivity, that I will go into it a bit detail later.
Okay.
Right? So that's why when you have serious illness like Parkinson, stroke, heart attack, or cancer, any form of cancer, post that 30% of them will develop depression. But of course, some of them is totally not treated, not identified, because so that you think, oh, of course you got cancer, you must be sad. This is not true. There are people with cancer, they are so optimistic, they go for all kind of exercise, herb therapy. But 30% will be very down. So this is a problem that they are not identified and not treated. Let's go to the second slide. Now, so we talk about the changing the spectrum, how we view depression then to be last time and now. Okay, let's say 20 years ago, when I was a medical student, all right, oh, not so bad. During my time, the serotonin, you talk about situational versus endogenous, meaning what? Meaning that situational because there's a life event, your loved one die, you got depression. Endogenous, okay, the design is unable to explain, so they put endogenous. Okay, now we know it's the interplay of biology and environment. It's not so simple of situation. Then at the time, people thought that with treatment, the response rate, wow, is very good. The full recovery as the rule. This is what they think. But now we start to have a lot of data showing that this is progressive disorder, reverse outcome over time. Just like diabetes and blood pressure, they at the end they will end organ failure. Okay, even though of course you take care, you take your medicine, change lifestyle, yes, it will help you. But some is chronic. You cannot do anything about it.
See, that's so sad.
Yeah, but because of this finding, we had to treat aggressively. Now, 30, 40 years ago, no non-cell pathology, possible chemical imbalance, what I say. But now we have emerging evidence, we're talking about the chain of the cell, the change, and the volume and the quantity, and even the second messenger. I go into it later, all right? Then you can see the changes in the brain, the structure, and the molecule. So at the time, for treatment is wait and see. We see whether maybe 1 week will be better. Maybe your son will care for you more, your spouse will treat you better, then you just what I call it, habit-based prescribing means actually the time in the 70s they don't know. Not talking about 70, even now, I do hear few cases and
For
this
holiday lah.
no. The funny thing is this patient went to Singapore to treat. So the psychiatrist asked her, you want fast effect or slow effect? They said, what do you mean? Fast, when you take medicine. Slow, you read and we go for counseling. I think it's insulting to depressed patient. Talking about now, you know, I'm not 20 years, I said, I got a shock in my life. Hey, they say such thing, you know, right? You want fast outcome or slow outcome? I think it's a nonsense, I think. But now we know you have to treat aggressively and not every patient is the same. For example, patient A respond well with treatment A, combination of medication A, and her friend suffer the same thing and her medication give it to him, it might not work because everybody is different, right? Now, so there are 4 things that I will go through. Number 1, nature and nurture, who is at risk, right? And second, what happened in the brain in depression? Number 3, antidepressant, the monoamine theory and neurotropic factor, we talk about that. And number 4, what's the clinical implication? Because when we know 1, 2, 3, then how are we going to treat the patient? Right?
Very good.
Now, so this is genetic, okay? This one is done in about quite long ago, you know, 2002. Now, we know that the monoamine hypothesis of depression using serotonin. Now, what they do is actually this research is quite, I would say quite smart. So what they do is they identify the gene for the HTT, the serotonin transporter. Okay.
Okay.
Now you see on the top one, the light blue, that SS, they mean that the short plus short and lay for the HPTT transporter. And the green one will be 1S and 1L. Then the last one or LL. So what's going to happen? You look at the graph. On the left side is the probability of major depression. Okay, episode 0, 0.1 to 0.5, and on the horizontal will be number of stressful event. Now, you see,
yeah,
yeah,
you can use a pointer. You look for it and see.
hold
On your screen, there is a pointer.
Remove control.
No. It's on the screen. You just use a pointer if you want. You can look for it. Never mind. Okay.
Wait, see, yeah, this one I want to ask you the
at the bottom there's a pointer.
Pointer or top?
There you're using pointer there?
Oh, okay. Yeah,
Okay.
got it.
Yeah.
Now, you see, 1, 2, 3, 4 refer to stressful life event.
Okay.
For example, what are the life event? Divorce, marriage is a life event, you know. Don't ever think that marriage is good for you, right? Okay.
Okay, we shall not talk about that.
For example, your loved one die, loss
Okay.
of job, all those life event. So what's going to happen is they follow up is quite a lot of patients, not 1, 2, you know, is in each arm will be 146, 435, and 264. Now, let's say they follow in one life event, those who develop depression about the same. By 2 life event, then you find that the light blue SS will be higher, become depressed. But once you go to 3 and 4, you can see the clear separation. So the orange color with the LLL is much less compared to SS, right? This is science. This is not people simply talk. Okay.
So
but
this
of course,
is genetic testing, is it?
Yeah, genetic testing. So
okay.
they find the gene and then they follow up. Okay.
I see.
Yeah. So then we go to second slide. Oh my God. No.
So basically what you're trying to say is for every unfortunate life event, everybody would feel some form of sadness or depression
Yes.
and have problems to get over it.
Yes.
But if you are of a certain genetic make,
Yes.
you
You
every
will develop.
unfortunate event becomes accumulative, your
Yes.
sadness. You
Yes.
accumulate,
And
you don't recover, you accumulate again, and then you accumulate again.
no, that means you're going to get depression.
Yes, okay.
Now the one problem is how come?
Next slide, please.
Yeah, this side cannot move. Oh God. Hold on.
Can. You just
Hold on. Where's the button already?
now you just did. Just go up lah.
Yeah, but the problem is I do okay. That means if no pointer, then only can,
Are you
Oh.
sure?
Yeah.
Okay.
Now, this is very interesting model. Kindling. So kindling means that you barbecue or you smoke cigar, you burn it and you sort of blow at the time the light out and burn. Okay. Now,
Okay.
this model is for epilepsy. So what they do, epilepsy, right? The kindling model of seizure. Now, this is animal study, not human, right? So what they do is they put millisecond of electrical impulse to the amygdala of the rat. You put one simulation, nothing happened.
Sad.
Then
Okay, go
two, nothing happened. Three, nothing happened. Four, like, then the fifth. Then you find that they start to have a fit.
Seizure.
Okay. Then of course, the more you give the electricity, more fit. Then after certain stimulation, even without any stimulus, you're gonna have spontaneous fit. That's why you see a lot of people having fits. We can't find what's wrong with them, but they start have fits. Now, let's say this one in the brain. Let's say we talk about this one to human hypothesis. Now, let's say the what do you call it? The light stressor for the human, no depression. Second, also no. Three, also no. Four, also no. Just like those sad movie, either Taiwanese or Tamil, everything, house burn down, husband die, you get cancer, then you paralyze, all kind of thing, right? So
depression.
now nothing happened to them. Then what's going to happen is the fifth one come, okay? Then the depression will come in already. Now, so that's why this is how we explain. A lot of patients telling me, doctor, the last 20 years, I had to face so many things, but I'm all right. I'm okay. I still can go to work. I still can take care of the family. But now I got this VSS. Then I got depression, right? So of course, the more you get it. Then suddenly the person say, now I'm retired. I got a lot of money in EPF, but how come I got depression? Because the cleansing model is starting already. Now, without any stressor, you're going to get depression, right? It's very clear cut, you can see. Now, so we talk about risk, right? So, number of previous episode depression, then the risk of depression, of course, the more is higher, right? So this one is they do in 2000 something, this the female they follow up is twin study. Then of course they find that this one is odd for depression. They find that it doesn't matter how many stress event, your depression will going to go up. Okay, what the graph telling you is that once reach certain episode of life event, even though without life event, you're going to get depressed anyway. Right? So now we know there's a nature and nurture, number one. All right. Okay. Then number two, we go to what happened in the brain. What happened? Right? But of course, let's say you have a tumor, you can get MRI, you can see. But when talk about molecular level, you can't see. And you cannot do this thing in human, unless you like the Second World War, the 731 unit, the biological research by the Japanese Imperial Army in Harbin. So that, but at the time they don't have PET, they don't have all those sophisticated thing. But I'm sure if Third World War, I think certain countries will do this kind of experiment in human. Yeah. Now, So this is our brain. This is the front, this is the back. So what I can do is I show you how. Actually, in depression, we concentrate on few area only. The prefrontal cortex, right? This part, the decision making, planning, judgment, and further down near our eye, the part is social interaction, maternal behavior. Then near the cingulate, the anterior, is for empathy, emotion. Oh, okay, hi. So this one you go back and read yourself, lah. Right? I still cannot remember lah. Unless got exam, if not I
This
cannot remember.
maternal behavior is what?
Okay, I tell you what. Okay, maternal behavior is now. So what they do is in human now they have this functional PET scan, meaning that real life they can see the activation of any brain area. They give the stimulus. Okay, so this maternal behavior meaning that this person will show a photo, adult and baby, and they find that when they show the photo of baby, and this area it
Light
becomes
up.
black, lighten up. Okay, so they call it the maternal instinct behavior, right? For example,
Does it happen to men also?
yes, man, yes. Of course, men will play with baby also, isn't it? Right?
Or are there people with no maternal behavior at all?
Which I believe the whole body can get impaired. Why can't this area cannot be impaired? Let's say the psychopath.
Oh yes, okay,
The
okay, I
psychopath, they
understand.
get impaired. So for example, the psychopath kill you, and
Yes.
his thinking is, you deserve it because you're stupid enough for me to con you, for me to kill you. There's no remorse, zero remorse, zero, right?
Okay.
So this is, now we know which part of the brain, what their function, then what happened in depression. Okay. Now, so in depression, what they do is they'll concentrate on all this part, right? And we have depression, we're talking about, they have feeling, memory, absent-mindedness, okay? They can't think, they can't concentrate, they don't care about baby. For example, postpartum depression, the baby is supposed to be happy, isn't it?
Oh
But
yes.
you hear of psychosis, they kill the baby and they jump down, right? What can happen is there's some abnormality in the part of the brain.
I see. So the maternal, what do you call it? The maternal side of this anterior
Yeah, because
cingulate cortex is
it's more of
disease.
feeling guilt, right? For example, this world is dark, right? It's pointless. I don't feel like I don't feel like living, right? So some will take the baby, and some they can't feel. You just see. Let's say you have chance to see people with postpartum depression. It's very clear cut. They tell you they do not have feeling towards the baby. And I see one kid for 3 years, actually, for 3 years. My God, he said, Don, what happened to me now? I don't feel I have attachment to my baby. Even 3 years old, he feel
I
empty.
see.
So you see, it's very sad. Actually, the patient very sad. She can go to work, but this part is not there, But fortunately, after a few years, now study coming back, or maybe he lied to me, so they want to show their good mother, because sometimes they feel guilty, You see such thing that I don't feel any emotion towards my child. This is socially not acceptable. Okay, so then we go to another slide now. So most brain imaging studies show abnormality in this area: amygdala, hippocampus, prefrontal cortex, and serious cingulate, and the OFC, right?
So in
And
patients with depression, there is actually physical evidence on imaging to show this area have abnormalities.
yes. I mean, you got a
Oh,
shock. You see, first time when in a group, we discuss depression, anxiety, and how are we going to take all the basic science experiment and put it together, the link to clinical, right? So
that's right.
actually, so that's why it's quite interesting. When I attend the workshop, everybody, what they call it, brainstorming, then we put out the slide. Okay, now, so then their study found that the prefrontal cortex hypoactivity at the baseline improved after treatment.
Oh, very
And
interesting. Okay.
Yeah, because this one is a molecular level and structural, not something like talk, whether this COVID-19 from where, whether this I think still we don't know what the hell is it also. Okay. Now, the finding limbic hyperactivity also normalized as the treatment. Okay, there are other things. Okay, now let's see. Right. So I think this one is a bit complicated. We talk about circuit level, introduce structure, beds out. I go in detail now. So we know in the brain, we are a neuron. In between neuron is what? It's a glial cell. Right? Glial cell is some kind of cement. Right? Now, what the glial cell do? They supply glucose to neuron. Glia protect neurons by stabilizing glutamate. Let's say glutamate is too much, it becomes toxic. They will kill the cell. This one in Alzheimer's. Now we find that we don't know why certain percentage of elderly they have increased NMDA.
So yeah, let me just mute this lady first. Still. This one very stuck. Okay, go on.
Okay. Now, so we talk about the function of glial cell, right? Also, they help in repair neuronal repair, survival, as Lisa saying now. What's going to happen in depression? In depression, you find that this glial cell, they reduce in numbers and become smaller. Now, so we talk in the graphic form, let's say control, neuron is the yellow triangle, and this dot is glial cell. We talk about genetic disease, Huntington disease, we have neuronal degeneration, the neuron degenerate, but the glial cell still the same, and it become more because there's more space for them. But in depression, what's going to happen is they find that they decrease neurocyte, possible atrophy, the neuron, and at the same time, the glial cell loss. Just imagine, you need glial cell for repair to supply glucose. Then it will depress, become small. So it is quite scary, Now, so what's going to happen is the glial immunoactivity in the prefrontal cortex. This is a control, all the bushy color, but those who are depressed, see, become less. Right? All these are the the logical finding.
So basically, you're telling us depression, okay,
Yes.
can now manifest, okay, not only as a symptom, but can be
Structural, cellular,
and pathological.
yes.
Also, we can see.
Yes.
Okay.
So you remember when we were a medical student, that time they do the post, they some part the change of the serotonin. Those suicide patients, right? So they have postmortem. That's why they find that this group of people has some anomaly with the serotonin pathway and the amount.
Yes, that one I know. But I didn't know that there were even
you see that time the question is it because he died, that's why the changes of serotonin? But now, because it advancement on neurological kind of the nuclear science, we can see their life. They mean the patient still alive, and we can see it. This one, 30 years ago, 40 years ago, we can't do it. Now we can.
Okay.
Now, so what's going to happen in this, right? The dot here is days of untreated depression. Okay, what will happen is on the left side, the vertical axis. Right? So long I didn't. So why isn't it? Why x isn't it? Why x is it? Oh God.
Yes, why?
Okay, so you see, right? Total the hippocampal volume, right? Now, on the x-axis will be the number of days of untreated depression. See, as the day go by, you find that the volume becomes smaller and smaller. Right? This is a thing you can do now. Before that, we can't. Right? So it's the same thing when we talk about the number of cells now. So the same thing. This is why I'm calling talk about the functioning. They can see, they can light it up. Right? So a person become fearful, they can see which part. A person is become excited or sad, they can see now. So all these things, right? We go through and do that now. So this is a bit complicated. Let me slowly deal through now. Genetic vulnerability. So means you have genetic. So you're unfortunate, you have stress also. Okay.
Okay.
Now, then what's going to happen is these two things will cause excessive cortisol, the glucocortisol activation, and this one also can deficiency of neurotropic factor, because stress and cause the brain neurotropic factor become less. So what can do is they cause younger depressed. So become fewer glia cell, and then depressed again. They increase glutamate. Glutamate got to kill more cell to become neurotoxicity and progression, depression, damage, and loss of neuron. So what's going to happen is you didn't stop it here. You didn't treat it aggressively. At the end, this is going to happen. Let's say you already had damage and loss of neurons. Nothing can be done anyway, right? So that's why you find that chronic depression, the older they are, they have episode, it becomes worse to treat, very difficult to treat now. So that's why they call it the treatment resistant. So number one, we see already, we see definitely there's a nature and nurture. Number two, we can see the changes in the brain in terms of the volume, the quantity, and what antidepressant will do in this way. Number three, we go. Now, this is a very interesting study in UK. What this person will do is they find depressed patients who respond to SSRI, meaning the Prozac, sertraline, Lexapro, right? So respond. When this one real life, when the patient respond, what they do is they inject a kind of chemical, they deplete the serotonin. Immediately, almost immediately, the patient can feel the symptom of depression coming back. Okay.
So sad.
Yeah, this is done in more than 2
So
years.
basically, the serotonin level,
Now, this
once depleted, the symptoms will come back again.
Yes, right. So, but interesting is, and we know for depression, not only serotonin, they know adrenaline, dopamine, agonamelin, a kind, or a lot of things that we still not sure. But let's see the SSRI responder, you go and block the noradrenaline, nothing will happen, no change. Now, let's say now we know that antidepressant, some are they put under the noradrenaline group.
I
So
see.
if you respond to noradrenaline type of antidepressant, for example, imipramine, but you deplete serotonin, no change. The patient said, no, I don't feel anything. But when you inject something to deplete noradrenaline, so the symptom return.
So
that's
you
why,
mean, sorry, can I just ask?
Yeah.
So there are patients who are depressed because no adrenaline level is depleted.
Yes.
And
some
what drugs does help with this kind of patients? Again, sorry,
now you see, in the early 90s or up to the mid 90s, what we have is the 5 serotonin medication.
That's right.
The Prozac,
That's the only one I know.
Out of 5. Now, then later in the late 90s, so what will come out, they had no adrenaline. So they call it actually is a 2+1 medication. Like your coffee, your Ipo coffee, the coffee that you have sugar, you have milk and
Oh,
coffee.
I see, a 3+,
So
okay, 3 in 1.
anti-hypertensive, same thing one.
Yeah, that's right. We have a combination therapy.
Yes. So now we have venlafaxine, duloxetine. Actually, it's a combination of serotonin and noradrenaline. Now we have, because we don't have the gadget that I take the blood, take the CSF and check and see which is it serotonin or noradrenaline. We can't do it. Right?
So you cannot tell from symptoms, from investigation, whether which group they are. So you just combine your medication and treat them as one.
Hold on. Oh my, wait. Hey, how come I had done?
While you're doing your slides, there is a okay, go
question.
on. We will take questions later.
Okay,
go
now.
on.
So they find that even though some of serotonin and noradrenaline, but a patient still do not respond. There must be something else,
Okay.
right? So that's why we come in dopamine. Also, and now we know that the antidepressant is not really increase the serotonin level or noradrenaline level, but what they do is they act of the second messenger. So for example, you see, so this is the, let me put here. Now, 5-HT is your serotonin, noradrenaline. What can I do is they go to the PKA, protein kinase, see, then go here and they become this and to the Krebs cycle and go to the what I call it, the DNA, then the messenger RNA. What they do is they produce the brain derived they call it brain derived neurotropic factor here. So all these things they help in synaptogenesis, neuroplasticity, cell survival, and neurogenesis. Right. So we know because 20 years ago, how we don't have the technology to see this kind of thing. Now we know, right? Now, so this one it just tell you what's going to happen. For example, this one in rodent, not human, right?
Okay.
Now,
Rodent no need.
so we're talking of so just tell you that this you can show. This one is the same now. This is very interesting. Now,
Okay.
you see control. This one with stress. Then stress plus antidepressant. So you see or not, the number of the BDA, the neurotropic is the same, control and stress. Actually very simple. This is very simple experiment. 50 rat, good life, good temperature, good food. Another 50 rat, you begin them warm and cold and take electricity and desert them.
Oh, please
Okay,
don't
and give
say
them less food, let them fight. But in the food, I put in antidepressant. So after 3 months, kill them, compare with the fat and the torture mouse. But actually, not much different. You will give antidepressant. So actually, before you get torture, you take antidepressant first, then you go lah. Right? So it's the same thing lah. Actually, another slide. So what
We
can
will
do?
take question at the end, no, Atika.
So you see, when depression, we're going to reduce all the synapses. Then post treatment, they bring back again, right? The synapse.
Amazing, this treatment. Okay, go on.
Okay, so the same thing, right? So what I do is stress, injury, genetic vulnerability, the interplay, then go to network level, the neurocircuitry, the neuroendocrine dysregulation, cellular level, and come out with all these psychiatric symptoms, emotion, cognitive, behavior, physical.
Do you mind speaking slightly louder?
Okay. Now, we know number 1, 2, and 3. So what are the clinical implications now? So we know that major depression is not benign and may be progressive.
Okay.
Major depression is associated with functional, cellular abnormality in brain areas mediating cognition and emotion. So by blocking reuptake monoamines, antidepressant ultimately increase the neurotropic factor rather than what we think is because of serotonin around internet is not true. Actually, it's deeper in the cellular area. So now we can new model of depression. Then simultaneous remission may be clinical best benchmark for enhancing probability of arresting disease progression. For me, they say, am I going to be better? How do you know I'm better? So
Symptoms.
put in the simply form is you go back to work, you go back to school, whatever you can do last time, you must be able to do. That means that you are recovered. But let's say you still can't, means that you're not fully recovered. Right?
Okay.
So in this fact, this one 2,500 years ago, so Hippocrates also talk about brain, all this kind of thing. Okay. Right? So, okay. So
Okay.
I finished the slide. So I think maybe we go for question and...
Yeah, questions and okay, so we have a question from Facebook Live. Mr. Lim Yu Chuan, maybe he's a doctor himself, I don't. He asked whether testosterone supplement can help men with depression.
So sometimes, you see, you think about it, the logic. testosterone to do what? Testosterone is a male so that you have the muscle building, okay, the aggression. Now we are talking about emotion. So actually, what is there to do with testosterone? So that's why a lot of patients, female, tell me, Doc, is it because of menopause? I say, for goodness sake, one is bottom, one is top. Is there any link? But to make you happy, you say, oh, I become so moody, I scold my husband because I menopause. But the problem is the whole family suffer. I say, it's due to menopause, you take HRT, what do you think called it? HRT.
HRT, yes.
You take HRT, your problem will solve already. How come it's still not solved? Now you are involved with the emotion. So go back to testosterone. Let's say, for example, oh dear, now I see beautiful girl, I don't have response. I cannot have sex. I feel that I'm very weak. Then you go and check level is low. Then you can go ahead and take some testosterone. But you can low mood, you are lethargy, suicidal, anger. This is not testosterone, right?
I think the reason, okay, I'm not sure, but I think the reason why people talk about testosterone is because it's they think that masculinity means being very manly, makes them less vulnerable to emotional depression, because depression is emotional.
Not
But
true.
in actual fact, maybe
Okay,
is it
stop
true
there.
that the depression is
Suicide
very,
rate,
yes,
suicide rate for male is 3 times female.
three
Suicide.
times, yes.
That means that you compete and you go heaven, go to hell, right? 3 times, right? But people don't really talk about it. You think about it, how, you see, attempted suicide, a lot of female, 2 to 1. But how come suicide is male is three times more than female? There must be something wrong with the emotional part of it. Okay, of course, you're creating your life is fulfilled already. You want to go for euthanasia. That's different thing, okay? The one we talk about in another session.
Okay. So Atika asks, is it possible patient who has depression to have symptoms such as hypersomnolence, short attention span, and poor memory, but no loss of appetite? I think that is very possible.
Yeah.
Yes, because
Yes.
some people actually eat more when they are depressed, right?
Yes. And they
Yes.
sleep more. But you see, when you call depression, for the young adult, a lot of them is not able to sleep. But for children and for elderly, actually they sleep too much, It is opposite. So the Simon say sleeping disturbance, meaning that either sleep too much or you can't sleep.
I think, okay. Atika again asked, do all patients, okay, Atika, let me just explain to you, in medicine, you will soon learn that whatever the textbook says, and lists for you all the symptoms and signs, you will not find anyone with the same exact thing. So when you look at and see patients, eventually you will see that some patients may have this, some patients may have that. So yes, they can have combination or not at all. So Atika asked, do all patients with depression present with blunt effect?
Oh, okay.
Blunt
Now,
effect.
how
It's effect, AFF.
you see, blunt effect usually we refer to the schizophrenic patient, right? Now, for depression, actually, for you to, sometimes you need certain criteria, right? So it's very important for treatment. There are two things in depression, two things. Either one must present, either anhedonia, cannot feel pleasure, all right? So you like to play badminton, now you do not. Second is the mood down. So depend on your culture. Either you feel sad, you feel blue, 或者是我好唔開心我不開心okay? You feel that your mood keep on down. So either one of them. Okay? So about blunt effect, the one different. The one we in depression, we just want to concentrate into these two main symptoms. Anhedonia, unable to experience pleasure. Second, persistently low mood. Then followed by another 7. Right? For example, like guilt, psychomotor retardation, hyperactivity, insomnia, change of appetite, of course, suicidal concentration. This is secondary factor. Let's say a person do not have these two, then very likely this person do not have clinical depression.
Oscar Cheong asks, do we need to treat cyclothymia? Is it possible that it will progress to MDD if we don't treat it early? I don't know what
Yes.
cyclothymia.
Yeah, cyclothymia means is persistently mood is low, but this person still able to function to a certain extent. Now,
I see.
if the person can feel this one is different from what he used to be, or not like other people, so now we know there's a changes in the brain. Why don't you go for treatment? Right? For example, your sugar is very high and your blood pressure is very high. I'm sure 80% of people without hesitate, they'll go for treatment. Of course, another 10-20% don't care lah. But the setting is in depression, I think about 40-50, they understand, they accept, or don't accept. And those accept doesn't mean that they agree for treatment, right? So acceptance doesn't mean that the person agree for treatment. When you say agree to treatment, actually people do not is taking medication.
So compliance is also a problem in
Yes.
depression.
Yeah,
Okay.
even chronic illness like diabetic, ischemic heart disease, also there's some compliance issue.
Of course. But we have not answered Oscar. So if we don't treat this cyclothymia,
Yeah,
will they progress?
maybe possible. Yes, possible.
That's possible. Huh?
Yeah.
So another question is Ayn asked if somebody has been diagnosed with MDD and has been treated for 6 months. After that, stop medications as they assume they are fine. Do you prefer them to take medication again because they want to become a houseman as a prophylaxis measure?
No.
Basically,
First,
what she's trying to say is that he's going to be a houseman, but he's fine now. Will continuing the medication allow him to perform his work better?
Of course. Now, if any treatment will not give you better outcome, then this treatment is useless. Then you stop treatment. The reason to treat depression or anxiety is so that you are better in terms of study as a student or working. Now, every time I tell my patient, yes, so this 4-year university, you graduated already. So far, so good, no relapse. Now, the person got a job. Now, during probation is 6 months. What if he or she like the job, but in 6 months, because of change the environment, and they had a relapse. So are you going to take the risk? Okay. So we're going to look, we go back to look at the data. We know that whether how long the person take medication, there's a lot of factor involved. For example, when they first present the time, is it very serious? Let's say it's very serious in the sense of self-injury, suicidal, and few weeks to month only respond with medication, number one. Number two, the strong family history, father, mother, sibling, uncle, auntie. And let's say these two appear, I will not recommend anybody after 6 months, and I don't think anybody, of course, there are some idiot also, ask you to stop medication. I think this is very bad. They're going to give you a problem already. And you remember, every time it come back, it will worse than last time.
So you are saying that depression is like, let's say, high blood pressure or diabetes, which is chronic illness.
Okay.
With the cure is not exactly a cure. The cure is actually a maintenance therapy.
So that's why I say you must look at it as biological. So unfortunately, I have short-sightedness. Am I saying that I've been wearing glasses for 50 years? I had to throw it away. I wouldn't do that. Okay. And there's good news for depression, all right? When you got diabetic, high blood pressure, ischemic, I think you should take your medication until the day you die lah. Okay.
Okay.
Right now, you see, in depressions, we find that, let's say the person had first episode, right, and not much of family history, and the episode is not so severe. You take for 1 or 2 years. This guideline is not my guideline, you know. This is over the internet guideline. I do not
Okay.
have a slide. A very interesting slide. They follow up 15,000 patients for 15 years. What's going to happen in 15 years? 85% had relapsed. So that's why, let's say your first episode, my advice is you take it for 1 or 2 years, then slowly tail down, then 50% in your lifetime, you will not get the depression again. But of course, 50% will come back. Once you have second episode, you stop your medication, you have 75% to get the third episode. Let's say you get third episode, you don't take medication, 99% will come back. Even though you take medication, there might be chance to come back also. So this becomes problematic already.
So Nukai ask, are there any other prevention of MDD besides managing stress? Okay.
You see, people will not think that way, you know. Every time I tell my patient, how come there are a lot of people go through so much of adversity, some from orphanage, they get torture, but they never have depression, never come to my clinic. And there are a group of people with wonderful family, they're brought up in a good environment, good career, everything good. Then starting bang, the mood down and suicidal. So this is to do with medical problem. Let's say you're born that your brain is very resilient. So even though you get a lot of problem coming in, you only get normal, low mood, and you continue to go back to work. You never go to all the symptoms of clinical depression. But of course, just like any health people, whether you had illness or not, then we have a normal, healthy lifestyle. For example,
I think her question is maybe what she's trying to ask is there, can we be watchful? Means every one of us, let's say, be watchful of our mentality or our mind so that we can actually prevent ourselves from getting depression. Is it possible? Can we train our mind even though if we have genetic
now
this vulnerability?
Okay, we talk about data, we talk about common sense.
Okay.
Let's say your father, mother have diabetes, your grandfather diabetic, and your sibling diabetic. Yes, you can go exercise, you have a balanced diet. In the end, you just delay the diabetic. It's not that you won't get it, okay? You're gonna get it anyway. But the problem is people do not see psychiatry in depression and anxiety as a medical illness like ischemic heart disease, diabetes, hypertension, SLE, all kind of thing. They just put it's a brain overpower, and you prefer to listen to Oprah Winfrey rather than a psychiatrist.
Okay, I see.
Right?
Okay.
So I tell my patient there are two ways. Either you buy coal or buy rope to kill yourself, solve the problem.
I don't. Okay. No. God, forget that he said that. He's not encouraging anyone to kill themselves. Okay. Are there other prevention that we've asked that already? Sorry, somebody asked, LT asked, does it mean that most patients need to be on medication lifelong? I think we have already answered that question.
Yeah, not all.
Yeah, that's right. Not all, but we should be on about 1 to 2 years if it's the first episode. At what point, Emily asked, at what point should a person seek for help when they suspect themselves to have depression? That's a very good question.
No.
Sometimes I may feel depressed. I may speak to my friend and they say, oh, get out of it lah, you're just a wimp lah, you know, you're just emo, your period is coming. At what point do they seek?
See, number one is disruption of function. And you'll find that in your work, you have concentration problem. You have ability to dedicate, you don't have the ability to interact with other people, and your family member to find that you are moody, or you become excessive quiet, and all these things the depressed patient know. Cannot be they don't know one, right? So not like diabetes and high blood pressure, it's a silent killer. For 10 years, you don't take medicine, you don't feel anything, okay? Even your pressure is high or sugar is very high. But for psychiatric illness, they can feel it, right? And especially those who can read, they go to Google, the symptom is all there, unless they don't understand the language. So the question now is not because they know or don't know, it's the acceptance for treatment. What is this? Yeah, for the last 30 years, I'm saying the same thing again, especially it's very difficult to treat who, the doctor, the family, and the pharmacy. These are the problem case, right? Because they don't listen to you.
Can I ask one question? You know, when you have schizophrenia or manic, okay, a lot of times they do not want to be treated because they don't have insight.
That different.
Does
Schizophrenia and bipolar, patient don't need to know. The family will take them for treatment, right? So depression, they can hide. Even now, I'm talking to you, and I'm going to kill myself later. Tomorrow you see newspaper, Dr. Yen jumped down. It's possible. I can talk to you nicely, and I already plan to kill myself later, right? So depression, the person will know. For example, like schizophrenia, bipolar, no insight, they don't even know, but the whole world will know, okay? That one is
whole
by force.
world, but in depressed,
depressed, you can mask it, you can keep quiet.
Article asks what assessment tools can be used to screen patients with depression, either the SAD person score.
Yeah, just like I said, the two things, right? Do you feel that persistently low for past 2 weeks and more? Do you feel that it cannot feel pleasurable? If they can either one, yes, then you go for the other 7 secondary symptoms.
There are a lot of questions now. Okay, Hafiz asks, what are evidence-based non-pharmacological way to manage depression?
Of course, I have a lot of enemy. I doubt it. Okay.
You doubt the non
So I'll give you an example, okay? Every time patient tell me what, no, doc, I can refer me to CBT, right? I think those audience hear about what is CBT, cognitive behavior therapy.
Yes, he is.
So I tell them, your mother and your grandmother and your father give you free CBT the day you are born. Do you know that? Now, we put it simple. Cognitive means what? So in the 70s, Adam Beck said, the time we don't know about this brain neurochemical, he said, you have this problem is because the way your brain thinks. So I change your thinking. That's why I say cognitive therapy. I change your thinking, then you become better. But of course, patients still kill themselves. Not better. Then about 10 years later, I think say, because of this your behavior, I change your behavior therapy. So they come as CBT. So meaning that they tell you, you change your mind, change your behavior, it become better. I say, do you know that your father, mother give you CBT? The day you born already, you know what the CBT they give you? Look at your neighbor, study so hard, now go university. Look, now they got big car already, you see the behavior change. So you better change your thinking and study hard. Every day you got CBT, someone gonna pay 500 ringgit per hour for CBT.
Okay, basically, Hafiz, let me put it gently. Basically, we're talking about clinical depression, whereby it can happen because of genetic, environment, and also other factors. And we're not talking about
the
situational depression. Yeah. So yes, maybe in situational depression where somebody cannot cope with their life, yes, you can try psychotherapy. But Yan is saying that he doesn't believe. So at what point should that one we have done? Sorry. Good evening. Let me see who is this. Sorry, I'm scrolling. AY. If someone was diagnosed with MDD, but totally defaulted follow-up and treatment and later presented with some delusion and subsequently became very aggressive and irritable to the extent of harming herself and other people. How can we get these people to get treatment? The patient is refusing help at all, refusing completely.
There are a few ways, okay? Number one is the covert treatment, meaning that family going to seek help, then they put the medication in their food and their drink. Now,
Okay.
And surprisingly is, once they are better, you ask them to seek treatment, 50% they will come, which I cannot explain why, okay? Now,
Yes.
Number two is no choice, because sometimes aggressive, you cannot hold him, then you get the help of the police, send it to the hospital. We are not calling the police to torture, to punish the person, to bring the person to inpatient treatment. You see, in Malaysia, it's very good. All the general hospital, the 24-hour, the psychiatric ward, just admit them inside.
Okay. Oh, so sad. Huh? Person with depression, Emily asks, a person with depression can have physical symptoms like tension, headache, and tension muscle, right? How can we treat? So we can treat by treating the depression and the psychosomatic symptoms.
You go away. You see, a lot of them with somatic actually is not only depression, actually having anxiety also, right? Anxiety, that's why I didn't in detail, but anxiety, we put a simple one is their true presentation. One, the emotional presentation, and then one, the physical presentation. Emotional presentation meaning that the person will feel that it's very strange. How come my mind keep on thinking the things that it already passed? I excessive worry, but sometimes my brain is non-stop. And second, they have breathlessness, difficult to swallow, neck very painful, phlegm. You go and check blood, go and see specialists, or will tell the person you are normal. Okay, so this is part of anxiety. Then maybe plus minus the depression also. So a lot of patients actually start with anxiety first, because not treated, the depression become more. So by the time you went to see the GP or the psychiatrist, they thought it's pure depression. So what happened is they treat the depression, but when depression is better, they still have residual symptom. Why? Because this anxiety is not treated. Because anxiety and depression, the medication is a bit different, right?
Okay. We have spoken for a very, very long time. It's almost 10:30 now. It's 10:17. I think we will stop here. We will also like to say that following this, we will put it on YouTube, so you can watch it in YouTube. Dr. Yan is also on our medical forum on Telegram. So eventually, I will ask him for the slides in PDF and we will share it there. And you can ask more questions in our medical forum. So whoever is not in our medical forum, we are on Telegram under Beating Hearts Medical Forum. Okay, you can also watch our YouTube under Beating Hearts channel. And with that, I wish you good evening. And I'll see you next Wednesday again. We have scheduled a lot of webinars for the next weeks to come. See you. Bye. Thanks,
Bye.
yeah.
Bye. Yeah, good night.
Good night. Bye.
Bye.